Right, so today we are doing the third part of my talk, that was glaucoma and interpretation of glaucoma diagnostic tests. Previously, we were doing, I went through the case history, and we were saying that there are two parts of managing our patients. First and foremost, as Ankit mentioned, diagnosis, and we don't diagnose, of course, we just try to see what is, you know, not normal. So as very rightly said by Ankit, we just identify that and then we try to manage it in an efficient way. So last time we went through case history and diagnostics tests targeted at suspected patients. So we've done these two sessions, and today we're doing the interpretation of those tests that we performed on our patients. And next time, hopefully, I'll continue with the anterior eye assessment and the optic nerve head assessment to help us with our diagnosis and the tests that we have done, for example, visual fields and IOP. These cannot be used in isolation. So don't think that what I'm telling you today is a complete interpretation of our results, but it is sort of splitting the lecture in two different sessions. One is the interpretation of the test that we get from the machines, and then the anterior and the optic nerve head assessment on the next session, inshallah, hopefully in a few months' time. And then the last session would be about the management. And that small little statement at the bottom, in glaucoma, it's if there is no progression, there is no disease. So, reminder of that. So the three machine-related tests that we do in our routine test, as Ankit mentioned, NCT machine, the IOP measuring device, visual field test, and in few practices, when I look around, I see that they have OCT machines as well, which is a very good tool. But if you don't have it, it is still good to know about it so that you're aware of how this machine works. And if you are in a place and you're presented with a result of OCT, you're not caught by surprise. So intraocular pressure, Ankit's favorite machine, as he was mentioning. This is a new intraocular machine, which is non-contact tonometer, of course. And this one has the advantage that it gives you the pachymetry result along with it. So that's quite handy. So it's a non-contact tonometer. It's easy to perform, good for screening purposes. I wrote less accurate, but I think that's a bold statement. I can't say it's less accurate, but of course it's not Goldman. It's not the gold standard, but it's very good. And it gives you a good screening test, basically. And if the pressures that you receive, if the IOP is high with intraocular pressure, we just repeat it with contact tonometry. We don't do that contact tonometry as our first choice because we have to put the anesthesia in the patient's eyes and it's a bit more intrusive. Therefore, non-contact tonometry is simple and easy to perform as a screening test. When I mentioned, as Ankit mentioned as well, that central corneal thickness or pachymetry, as he mentioned, Goldman, which is our gold standard, if I'm not wrong, I think it is measured, it was calculated around 550 to 555 sort of corneal thickness. So that's our sort of average that we need to keep in mind. And when we get the result from this non-contact tonometer, it kind of displays on the screen like this, where you have the pressures at the bottom, 13, 12, 12 in one eye, an average of 12, and then 15, 14, 14 in the left eye with an average of 14. With this machine, you've got few other numbers, which are, I think, yeah, there. These ones are the results of pachymetry. And what it does is it's given you an average thickness of the cornea, central cornea, at 548 in the right eye and 54. My own video is blocking my view. Okay, so 545 average of the other eye. Now, if you see at the bottom, it says corrected IOP. So this machine is giving you the pressure without correction as 12 and 14, but after correction, it is giving you 10.9 and 13. I don't use these pressures. I would always record the normal pressures without considering the central corneal thickness, because not every colleague of mine, if I'm referring, or if the patient decides to go to another practice, they might not have this new machine where the pachymetry is also part of it. So if I'm recording the pressures in patient's file, I will record the normal pressures, i.e. 12.3 and 14.3 in this example. But it is good to know that how the pressures are adjusted, and this machine will help us in our decision of referring onto the hospital service. And in this example, you've got the central corneal thickness, which in the right eye as 495 and 510 in the left eye. So as you can see, the pressure adjustment from 17.3 in the right eye, the pressures have been adjusted to 19.1. So that, I'm sure we can appreciate that if the cornea is thinner, it is giving us a false reading that it is the pressures are low. That's why with the Black African community, we see that they are at a higher risk of getting normal tension glaucoma, because the pressures, it could be one of the reasons that the pressures are always considered normal, whereas it might not be, because the corneas are generally, the central corneal thickness in that community is always lower as compared to the Caucasian community, where the corneal thickness is higher. And in those patients, if I see that the pressure is higher, like 24, 25, 26, but in both eyes consistent, and on a repeat it is also the same, then I would consider that the central corneal thickness is high. And if I don't have pachymetry because of their race, I would be satisfied and I would not refer, because there's no other associated problems like visual field defect or optic nerve looks healthy. So just on the basis of high pressure for a Caucasian community, I would not refer, considering that the thickness of the cornea would be high. But if the pachymetry is part of your machine, that's a good tool. If you have to repeat, now when would you repeat? If the IOP is higher than 24 in either eye, so repeat the pressure on a different time of the day to confirm before referring, of course keeping in mind the central corneal thickness. And other option, another time that you would consider of repeating the IOP would be when the difference between the two eyes, the pressure IOP is more than 4 millimeters of mercury. Ideally, repeat it at a different time. For example, if a patient is coming to you at 9 o'clock in the morning and you have to repeat the test, try to repeat it in an afternoon on a different day, so that you get a nice variation, and also you can catch up if there is any fluctuation in the pressures. Other thing is that when you are repeating the test, make sure that the patients are relaxed, they're comfortable, and you advise the pre-tester or pre-screener, whoever is doing that test for you, that make sure that the patient is breathing normally. And sometimes when there's a repeat pressure going on, I tend to stand next to the patient and I keep telling them, breathe normally, think happy thoughts. Generally, it really relaxes them, but just a simple thing like think happy thoughts, it really calms them down, and the pressures generally tend to show lower readings. And just make sure that the top button is untied, and if you're not wearing a tie which is too tight. Right. Previously, I mentioned that the fluctuations are not a good sign, and you can go through previous lecture that we went through, and also here's a little bit of information or a quick revision of 2 slides that I shared last time, that where and how we can get the fluctuations and how to handle them. but be mindful of fluctuations. Therefore, we need to do repeating the IOP on a different time, on a different day is always good, so that we can catch these fluctuations. Right, after pressure is done, then we move on to visual fields. As Ankit said, it's a very, very important part of our test. And visual field is a subjective test, so it has certain problems with it. For example, possible difficulties that we see is the patients don't understand the test very well. And another problem could be that if they do understand the test, they don't have the ability to perform it for various reasons. It could be Parkinson's, or it could be any other delay in their response, or muscular problems. So it could be a variety of things, but it's a subjective test. So we need to make sure that how do we fix the first problem? We make sure that we perform the test on ourselves first. So if I can do the visual field test, then I can appreciate that how the patient and what problems the patient might face. You're basically a bit more empathetic to their to the patients, and also then you will be able to give them the clear instructions. And then make the patient comfortable so that they can perform the test well. So for example, if the patient is on a wheelchair, or patient has osteoporosis or arthritis and they have neck pain, so they just can't do that test. So you need to make sure that patients are comfortable, because it takes about 5 to 10 minutes basically to perform the test, and it's not easy for elderly patients to sit for that long. And also we need to repeat the test so that patients can learn as they do the test. So it's called a learning curve. So I never rely on the very first test that I performed on the patient, especially not for referring purposes. So I would always use my first test that I've done on the patient with visual field as it's just like a trial, and patient, just to get the patient familiar with the machine. And then once they are happy, they can perform the test and a bit better. They're learning, they understand the test better. This is the website of Vision Arcade. Just to show you what field defects and you can get, and also why is it important to do monocular visual field test compared to binocular. So binocularly, if you're performing the test, you might miss out the fine details. So for example, in this case, we have a left field defect at the bottom and the right field defect on the top. And if I remove, for example, the right eye, so this is a monocular view with left eye, that this is the visual field defect that the patient would see. Whereas the right eye, they would see just the top part. So now, if we do binocularly, what would you expect? Would you expect that the patient's view would be this, or it would be like this? I hope, I'm not going to ask a poll or a question in this session, but I hope that you appreciate that binocularly, patient's view would not be this, but it would be this, because they would not see the pathology or the field defect, because each eye is correcting the field defect for the other. So it's very important to perform the visual field test monocularly. And in glaucoma, when you get the field plot, what are you looking for? So I'm looking for these, certain signs of visual field patterns which are associated with glaucoma. So when you see these pictures, as you can see here, I can never make sense of them, or at least it is good just to understand what is nasal field defect, what's some temporal wedge. But when you get the HFA result, they're nowhere near like what you're seeing here, because they look something like that. So when you see a nasal step, don't expect to see exact textbook images, but actually you're looking at the pattern which is sort of building or starting. So this is like a common and a very famous nasal field defect, nasal step in the glaucoma patients. And then this is an enlarged blind spot. And this is how a arcuate field defect looks like. And this is a pattern deviation. I'll talk about that in a bit more detail later on, that why pattern is so important. And this is the temporal wedge. This is how the visual field would look like, and that roughly, in that area where on the temporal side, you can see the damage at the bottom right. And this is a sequocentral bilateral sequocentral field defect. This particular patient that I've taken the scan of, this is not glaucomatous damage, it's something else. So I don't normally like to consider this, especially bilateral equal defects, very unlikely are going to be glaucomatous, because glaucoma is a progressive disease. One eye progresses more than the other. So if there is a symmetrical pattern coming up or showing in glaucoma field defect or visual field defect, I would be more worried about neurological problem rather than glaucoma. Because in glaucoma, I'm expecting more sort of a unilateral defect and asymmetric. So we'll leave that away. If you get the visual field results, what's the first thing that I look out for is, as Dr. Pacey in our Bradford University, he mentioned this acronym WANDA. That's what first thing that goes to his mind, and I'm being a student, I also follow that, which is what was done, i.e. which eye was test was done on, which test was used, and we'll go through that in a second in another slide, and then how accurate the test is. Again, I'll show you where we check that on the field plot. It would be fixation losses, fixation, and also that some figures on the side they'll come. Is the field normal? If it is normal, good, we're both happy, let the patient go. But if there is a field defect, then we need to analyze what sort of defect is it, and is it a pattern that we can associate with glaucoma. So we need to evaluate the field, and then can we repeat the field? Is it repeatable? Because if it is not repeatable, then there might be high false negatives or high false positives. There is something going on that the patient is making a mistake. Sometimes the patient is seeing the plots, the spots, and sometimes they're not. So you can't get the same plot more than once. Then that means it's not a repeatable test, and you can't refer on that unless you have at least two consecutive field defects on consecutive tests, which on repeat are showing you the same result. Then I'll be more confident in referring that patient to hospital. Right. So, for example, this is the field plot that you get, and how do I go through this? So, in this printout, I can see that we've got right eye that was performed, and yep. I can see that what was done. The right eye was done, and then in the middle circle, you can see the strategy that was used was CETA standard, and the test that was performed is 24-2. That's the field of view that the patient was tested in, and it was a threshold test. Central, 24 degrees of the field was tested. There's not enough time for me to go into more detail about these, but hopefully we'll get more chance to go have a full lecture just on visual field, and then we can go through all these things again. So this is about the accuracy, how the fixation was monitored. Was the machine was checking the blind spot by method, or was the examiner looking at the gaze of the patient? There's a small camera in the visual field machine that you can keep an eye on and track if the patient is looking at the right spot. And then fixation target, was it central, or was it a diamond that was used, or was it a bigger diamond that was used? Again, That's a different type of targets that we can use in visual field machine. Hopefully in visual field lecture, we can go in a bit more detail with that. Fixation losses, how many are we allowed to have, before you start getting the two crosses next to that fixation loss? So in our case, it's 1 out of 15, and there's no 2xx next to it. If it is more than, I think, 15 or 20%, then the machine will show 2xx next to it. That means the test is unreliable and patient's fixation is not good. So we'll have to repeat that test basically. And then false positive errors and false negative errors, again, they are the threshold or the cutoff point is 15%. If patient's false negative errors are high, then that means the patient is probably getting tired and will need to repeat the test later on. So what does false negative and false positive means? Hopefully we'll get a chance to go in a bit more detail in visual field lecture, and the test duration. How long did it take to perform this test? This is also very important, because if patient did, for example, in this case, it was CETA standard, but if it was CETA fast and the patient took 7 minutes to perform the test, there is something wrong. So the duration of the test is also very important to keep an eye out for. Then you have certain numbers which talk about the sensitivity of our patient compared to the normal population. This is the deviation from normal population. So on the left side, you've got total deviation, and on the right side, you've got pattern deviation. These two are very important to understand and appreciate that how they differ from each other. And I'll go through that in a bit more detail later on. At the moment, let's move on to this. On the right side, you've got GHT. This is glaucoma hemifield test. What that does is basically this has 5 points on the vertical plane, on the horizontal, midline. On the top of the visual field plot, it tests 5 various points, and then it does a mirror test on the opposite side. So if it is checking the top of the field, it checks the same spot at the bottom and makes sure that the both sensitivities are similar. If they are different, that means there is some problem. And this glaucoma hemifield test is quite a good tool, quite a good indication for finding any early pathologies, especially the arcuate defects. And it would show normal if everything is good. Otherwise, the 2 other options that you can get is borderline or outside normal range. Basically, that's another option that you can get. So mean deviation is another number. If it is 0, that means it's close to 0 is good. But if it is a problematic eye, a glaucoma test damage, you would see a higher minus number. So -2, -10, -14, that's showing basically the pathology is high and the patient is away from the mean. So a high negative number is problem in MD, and if it is close to 0, we are happier. And if it is above 0, that means it's too sensitive, but more sensitive than a normal person. And pattern standard deviation, this is about the pattern deviation, and in this, what you need to know, we can go in a bit more detail in visual field lecture, but here you just need to know that if it is close to 0, it's a problem. The higher the number, the better it is. So it's opposite to MD. So MD, the more close to 0 it is, that means the patient is normal. And PSD, if that number is higher, that's where we are happier. Actually, other way around. If the PSD is higher, that means the patient has problem. Close to 0, we're happy in both of them. 0 is our target, basically. And then next is at the bottom, you can see that these numbers at the bottom that you see, they're just there as a key to indicate that probability levels, basically, that the pictures that are presented at the bottom which on top you've got total deviation in numerical form, and at the bottom is more sort of a graphical form. And these numbers, 5%, 2%, 1%, and 0.5%, are basically a key for these squares that are displayed in these pictures. And this is the probability that less than 0.5% of normal population would miss this spot, whereas this patient has missed it. So that means it's a problem. Very few people would miss this spot, and this patient has missed it. So that's what it is showing, that in probability, the higher one on the top, 5% of the population would have missed it in normal population. So if this patient has missed it as well, it's not a problem. It's 5% of normal population. So this is sort of a probability test, that the numbers that are there. So sometimes so many numbers can confuse us. Clearly confuse me for sure. Total deviation versus pattern deviation. For this, I have tried various ways of trying to explain this to students, and the best way I've found so far is this, and I'll try to show it to you. If I stop sharing my screen and go back onto my video, and I show you this bowl, it's like the island of vision that we all have. So if I put this down towards the table, so I've got a bowl here. This is my island of vision. And then this vision, this is a normal island of vision. But this bowl, these two bowls are like the defected island of vision. So now the patient has lost the sensitivity because of either corneal sensitivity being affected, or cornea opacity, cataracts, anything like that. The island has been reduced to this size. So this is the original size, and this is the smaller size. The smaller size is now, this is our total deviation. And now we can't detect if there is any pattern inside it, because it could be glaucoma, it could be corneal problem, and also it could be cataracts. Everything is suppressed further down. But what the machine does is it adds to this sensitivity plot 7 degrees or 7 steps higher. So it adds 7 onto the total deviation, and what that does, it exposes any pattern which is underneath. So you've got Marvel looking from top, this is your total deviation, but when you add the 7 points of sensitivity into the total deviation, that raises the whole island, and it exposes that this is actually Mrs. Peak's pudding company. So what I'm trying to show you is that a pattern is hidden inside the total deviation. We cannot see that pattern unless we expose it. And the machine and the algorithms which are inside the visual field, or HFA, and all these machines that plot these pattern deviations, that's all they're doing. They're separating the total deviation with pattern deviation by adding certain amount of, or 7 digits, literally, they increase the total deviation and exposes the pattern deviation. If you didn't understand that, don't worry, I'll try to go through in a bit more detail in visual field session, and hopefully you will join us then, and we'll arrange that soon. So moving on to the next thing, which is OCT. I hope I haven't taken too much time. OCT, the 2 things that are very important for me, one is the retinal nerve fiber layer thickness, and how that is displayed is on the left. If you look at this picture, I'll go one step back to move that. You've got, there is a red ring around the optic nerve, and the area between the optic disc and this red line is basically displayed here in a linear form. So imagine this is like a orange, peeled orange that you've taken, but then you've opened the oranges and separated them and aligned them in one straight line. So now you can see the thickness of the retinal nerve fiber layer around that optic disc. And also in this area, this is quite a good graph. I like to show this to my patients as well, because it's easy to understand. That if this black line was in the green zone, that means you're among the normal population, nothing to worry about. But if it is touching at various points, if it is touching the red zone or the yellow zone, then there is some pathology or some problem, or we need more investigation of this patient. And you can see in the right eye, or it's the left eye. So the left eye is normal, it's within the green zone, but the right eye is sort of going further down. So this is the retinal nerve fiber layer. That's the thing that I look out for when I'm trying to interpret the results. And then you've got, which is very important, ganglion, optic nerve head and retinal fiber layer. And there is also another layer, which is ganglion cell layer, which is very important. I think I might have deleted that by mistake. No problem. But ganglion cell layer, I didn't save that picture. But these are the two thickness plots that I need to look out for. One is retinal nerve fiber layer thickness. Second is ganglion cell layer thickness. And ganglion cell layer thickness is very, very important for assessing the glaucoma progression, because what you need to know is the thickness usually is 68 micrometers to 100 micrometers. So if it is in that range, we are happy. But if it is sort of going below 70s and 60, below 68, even the machine is going to start showing you the red sort of red scans, red patches on the retina. So ganglion cell layer thickness is very important. And in retinal nerve fiber layer, in this plot on the right side, what I want you to highlight here is certain digits which are recorded. And most important one over here is, for me, is disc area. That's the first thing I look out for. Although CD ratio is quite good, that makes my wall cleanse a bit easier. But I don't rely on the CD ratios from here, because I like to see it through the wall cleanse personally. But this disc area is quite important, because if the disc area is too big as compared to the normal population, then the reliability of OCT is reduced. So you need to be aware that what is a normal disc area, I would say from 1.8 micrometer. So in our example, it's 1.6, it's good. So 1.8 millimeter to 1.7. So that's the normal average. But from 1.2 to 1.7 is small disc. 2 to 2.27 is a large disc. So if the OCT and this disc area is displaying that the disc area is 2 and above, then I will be a bit more cautious about relying on these OCT results. Otherwise, because it might show you redness, and you start referring because the OCT is showing red. That's why you're referring. So just be mindful before you refer. Check that disc area and make sure that it is it's within the normal range. Okay, that's it. I think I tried to keep it brief, and if you have any questions, feel free to ask. But one more important thing I would like to say is all the tests that we've interpreted, they are useless without linking these tests with the anterior eye assessment and the disc assessment itself. So we cannot manage our glaucoma patients or even diagnose in isolation. So IOP, visual field, optic disc assessment, and relating all these together is very, very important to come to a conclusion that the patient has glaucoma. I hope it was helpful, and I'll be looking forward to answering any questions, and hopefully till next time.